Good afternoon, everyone. Welcome to CEDA's live stream on improving mental health outcomes with virtual care. My name is Cassandra Windsor, and I'm Senior Economist at CEDA, the Committee for Economic Development of Australia. Today's event is part of our series of events and research on human services, looking at how we can more effectively and efficiently provide the high-quality services that the Australian community is increasingly demanding. CEDA's recently released work in this space around the aged care workforce, including the role of technology in the workforce, and also on how we can use data to overcome entrenched disadvantage. This year, we'll be progressing further research into the role of the workplace in mental health and wellbeing, and also looking further at the links between human services and public interest technology. So stay tuned for more events and research on related topics. CEDA acknowledges that today and every day we're on Aboriginal land. Committed to recognition and reconciliation, we respect elders and we support their stated aspirations. Today I'm coming to you from Perth on the land of the Whadjuk people of the Noongar Nation, and I'd like to pay my respects to the elders past, present and emerging. The work that CEDA does is only possible through the incredible support of our members. To that end, I would like to acknowledge the sponsors of today's live stream, Philips, and to thank them for their ongoing support of this event and many others. We really encourage everyone to get involved in today's discussion. One way you can do that is through Twitter. So you can follow CEDA on Twitter at CEDA_news and use the hashtag mental health. And we also strongly encourage you to ask some questions of our panel today, which you can do through the Pigeonhole app. You can join directly through the live stream page or go to ceda.pigeonhole.at and use the passcode virtual care. You can enter your own questions, or you can also vote on the questions of others. I would also ask that you take a moment at the end of the event to rate your experience in Pigeonhole. We have a great lineup of speakers today, and I'm looking forward to hearing their thoughts on such an important topic, and one that's really come into the spotlight through the COVID pandemic and the increasing use of virtual care. I'll now hand you over to Thomas Crawford, who's the Health and Human Services Technology Business Lead at KPMG. Thomas is going to introduce our speakers and facilitate today's discussion. Thanks, Thomas.
Hi everybody, and thanks very much, Cassandra. I hope you can hear me clearly. I also wanted to echo the acknowledgement of the lands that we're all so lucky to live on, and to pay my respects to elders past, present and emerging. Mental health is a pretty important topic, I think, to everybody, regardless of whether you're in the industry or whether it's just something that you've seen affect yourself or others around you. We do have, as Cassandra said, a great lineup today. The forum is, I'll do some introductory comments. I'll then hand to each of the speakers in turn to present, and then we'll have a panel Q&A at the end. Really keen for people to put their questions as you listen to the speakers into the chat. And we'll look to answer those questions either online or in the Q&A session to the best of our ability. Mental health is something that is important to everyone, but interestingly, it's become an emerging area of focus across society. And it doesn't really matter whether you're in politics, sport, everyday life, whether it's a family member or a colleague that you work with. I think we've all come to appreciate the importance of mental health. Not only as a clinical condition, but as something that affects everyone on some level or other. And the treatment of mental health has been an important part of an emerging field, which historically was a highly clinical environment, but now is treated more and more in the community. And what COVID has done is brought into stark relief the issues around how to best communicate with people in an environment where face-to-face treatment isn't available. It's also brought into stark relief the challenges of people moving between care settings. And what I mean by that is between an acute hospital environment and a community environment, and between different carers. And how do we get continuity of the treatment that those people need? There's already been initiatives in the past in this space, but what COVID's done is really brought them to the fore. And I think there was genuinely a nervousness at first that without face-to-face contact, that there'd be problems with providing continuity of care for mental health. But in point of fact, what it's revealed is in some ways the opposite, which is that many people value what in technical terms we'd call an omni-channel way of engaging them, where maybe a chat service, a video conference, particularly where there's an existing relationship in place. Virtual care has not only been shown to be effective, but actually critical to delivery of care. And I think it's something that will continue to emerge, and mental health may actually become a leader in the area of the adoption of virtual care. So I don't want to spend more time on that right now, because you're going to hear from some very impressive speakers that are going to really share their insights. They all come from different backgrounds and angles, so you'll get to hear quite a variety of thoughts, and then we'll try and bring that thinking together in the Q&A session. So let me individually introduce you to each of the speakers and then hand over to the first speaker to kick off our session. So the four speakers we have today is we have Shahan Fernando, who is actually the Regional Director for Virtual Care from Philips. And if I didn't say it already, I just want to thank CEDA and Philips for the opportunity today for all of us to get together and discuss this important topic. The second speaker will be Sonia Wiedemann, who is a team leader and therapy lead at West Moreton Hospital and Health Service. And if you follow virtual care, you'll see that West Moreton's actually a leader in virtual care in a number of fields. So it'd be great to hear that sort of first-hand feedback. Then we have Herbrand van der Beek, who's the Chief Digital Officer in Untitled Chapter, and Herbrand will have to forgive me if I've mispronounced anything. He's going to bring us some great international perspectives on the topic. And then Andrew Dempster, who's actually the Mental Health Advisory Lead at KPMG, who I work with closely and is heavily engaged in the mental health advisory area, both in virtual care and in other areas. So let's kick off, and I'd like to hand over to Shahan for his session. Thank you.
Thank you for the introduction, Tom, and really thank you to everybody that has attended this session. We're very excited to share with you some of the progress we have made in virtual care, and certainly you will hear, as Tom mentioned, from Herbrand and Sonia on some specific examples of how virtual care is being used in practice. The focus of my discussion today is going to be to highlight the opportunity virtual care presents in terms of an enabler of delivering virtual care. So what I'd like to do is I'll first give you a quick overview of who Philips is in terms of what we're focused on and how we're supporting virtual care. I'll highlight a little bit on the challenges that we see in the mental health space in particular, and then wrap up with how virtual care can support clinicians, can support patients in being able to achieve better outcomes in mental health. Philips has a 130-year legacy of innovation with the purpose to improve people's health and well-being through meaningful innovation. At Philips, we see healthcare as a connected whole, helping people to live healthily and prevent disease, giving clinicians the tools they need to make precision diagnosis and deliver personalized treatment, supporting patients' recovery and management at home and in the community with a seamless flow of data. And for me, this is where virtual care really brings it all together, because it's about how patients transfer from acute care settings into home care settings, and certainly in the mental health space, being able to be treated at home in the comfort of a patient's environment is fundamental to how they can improve in terms of achieving better goals for themselves and reducing the use of health resources as well. In the space of mental health, we've been active in this space for a long time. We've supported over 1 million consumers globally and 37,000 professionals. And through this experience, we've understood that the ability to deliver care that covers not just the mental health aspect, but also the physical aspect of care is fundamental to delivering those better outcomes. And you'll hear a little bit more about this in the next couple of minutes. First of all, from a mental health perspective, just like other clinical areas, there is a critical shortage of professionals. There's a critical workforce shortage, and added to that, there's also a maldistribution of professionals. So a recent AIHW report highlighted that, as an example, 9 out of 10 psychiatrists are located in major cities, and this is quite normal for a lot of specialist fields. So the ability to access care is quite challenging in this mental health space. And of course, in general, exacerbated by the COVID-19 pandemic, mental health services, there's just not enough of them as well. So there's a high demand and there's an inability to deliver on these services. Added to this, the siloing of physical and mental health treatment in general, what we've seen in practice is that they do go hand in hand. So some quick statistics to highlight this challenge for you. 4 out of 5 people living with mental health issues have a coexisting physical illness as well. And we know that patients with mental health conditions have two to three times higher likelihood of diabetes and a 6 times more likelihood of cardiovascular disease. So trying to think of mental health different to how you manage their physical health is not something you want to manage in terms of how you're delivering that care to patients. So with virtual care, the ability to bring these two modalities together becomes much easier, because as you're treating these patients, you're able to follow them in their healthcare journey when they go into their home as well, and wrap around their care in a more holistic way. So talking about the challenges you find in terms of the maldistribution of clinicians, telehealth as a medium of delivering care is not new. And certainly COVID-19 has made that even more normal in today's environment. But virtual care is not just about telehealth. Telehealth is a single intervention, and it has almost a one-to-one resource model in many respects in terms of how a clinician delivers care to a patient. The opportunity that virtual care brings to how care is transformed is the relationship between clinician to patient effectively can change to a one-to-many relationship. And the reason that is achievable is because the platforms that support these clinicians in managing these patients in that home environment highlight to the clinicians when a patient needs care at a particular point in time, rather than today's traditional care models where it's sort of based on a consult model. So through virtual care technologies, this maldistribution of physicians and the ability to care for patients at scale with a smaller group of clinicians becomes much more achievable, because the technology helps a small group of clinicians manage a large group of consumers and patients in the community by just focusing on those that need help at a particular point in time. And when you think about mental health, a large part of the shift that you see in terms of delivering better value comes to behavioral modification, the ability to impact how they feel about themselves, the ability to impact how they're going to make lifestyle changes. And we all know, I'm sure everybody here has had that experience, that you're only going to drive change when you're ready to accept that change. And the opportunity that virtual care delivers is that when a patient identifies that they need help, that allows the clinician to immediately intervene and support that patient, allowing for better treatment outcomes for that patient. So through functionality like diaries and chat function in the platform, clinicians can keep an eye on when patients need support at a particular point in time. There are 3 components to virtual care that I want to leave you with before I hand over back to you, Tom. It's around, how do you deliver effective virtual care? And there are 3 main principles, in our opinion, in terms of how you successfully do this. It goes across understanding the patient's journey, understanding the outcomes that you want to deliver for those patients. So, constant measurement of patient-reported outcomes, how that's going to change your models of care, how that's going to evolve your model of care, but also allows you to then personalize care for that individual. We all know that personalized medicine, personalized care is the future. The ability to capture these large amounts of data from individuals at many points in time in their healthcare journey allows clinicians to really personalize care in that journey. The navigation of care, then, the system allows clinicians to support these patients, as I said, in that home environment. The ability to have joint care planning, to build care plans together with these consumers, then leads to better activation of care as well, which is the last pillar here in terms of successful virtual care delivery. At the end of the day, if a patient is not activated in their care, if they're not part of that care cycle, if they're not a partner in their care together with their family and carers, then you're not going to get the outcome of the intervention that you want to progress with. So in a nutshell, these are the 3 components that we see globally as relevant to delivering a successful virtual care program. You'll hear from Zonia and her brand, how they're doing it. And I'm sure you'll see these principles coming into practice in terms of what they're saying. Thank you, Tom.
Thanks, Shahan. That was really good. And I must say, I'm a huge believer myself in care plans and the role that virtual care technologies can have in really bringing those care plans to life. So keen to get back to that during the Q&A. Now we're going to hand over to Zonia, who's from West Moreton Hospital and Health Service, and hear some real on the ground feedback on how this is playing out in the mental health space. Thank you, Sonia.
All right, good afternoon, everybody. So yeah, my name is Sonia. I'm the therapy lead in West Moreton. And with the, Shahan really mentioned this already, but with the critical clinical workforce shortages and the high demand on our emergency departments, I was tasked to set up a team called the Living Well team last year. And we provide psychological interventions to people with borderline personality disorder. We've adopted virtual care technology through the Engage platform in partnership with Philips to provide consumers the opportunity to have some control over their own recovery journey and to self-monitor their progress. Virtual care is not just video conferencing, like Shahan was saying, as you can see here on my slide. Clinicians can chat with consumers, we can provide education, we can see them virtually, we can ask for questionnaires to be completed, we can complete questionnaires with them, and the list just goes on and on and on. So if we move to the next slide, why we've stood up specifically a team to treat people with borderline personality disorder is, unfortunately, this consumer group makes up 10% of the admissions and presentations to our ED departments, and they are at high risk of dying by suicide. People with VPD are often trapped in a revolving door situation to ED and are not getting the treatment they need due to stigma and lack of resources. Through virtual monitoring, we are reducing ED presentations as we can provide assistance to a consumer when they need it. Our slogan here is the right treatment at the right time. Initial data and qualitative evidence are also noting that this approach is reducing the need for consumers with BPD to seek assistance from emergency services. It was really cool when the police and ambulance liaison services phoned me up and said, can we just check on the consumers that presents frequently, as we have not seen them for a while. So there's definitely a reduction in presentation. On the next slide, you'll be able to see how we use this. What do we actually do? Here, a consumer has completed a diary card, and this is only just a section of the diary card based on dialectical behavior therapy model. An alert is generated, and the clinician are notified if the consumer requires assistance to de-escalate. For example, here you can see is a consumer indicating their urge to self-harm. And so once again, we can provide that care when the consumer requires it. If they indicate that their urge to self-harm is high, the Living Well team makes contact with the consumer via the chat function or the video conferencing capability on the Engage platform. We then help them to regulate the emotion, manage the crisis, and avoid that emergency department visit. On the next slide, you'll see that another benefit of Engage is also automation. It saves clinicians a lot of time, and it gives us that time back to focus on consumers and their care. For example, outcome measures are sent to consumers automatically. We don't have to do that. It also allows for an enhanced collaboration as the clinician and the consumers working together on their care plan. Both Tom and Shahan noted the importance of care planning within mental health. And yeah, we can do it together. We can specify goals, we can specify time frames. And what's so important is the consumer can add updates, they can leave us little notes about what they've achieved. And the clinicians get the opportunity to really validate what the consumers are achieving. We are still in the infancy of this program. However, we're very, very excited to see what we can accomplish in the next year. The next slide is my contact details. So please make contact. We'll be very, very welcome to work with anybody who's interested in mental health. Thank you, Tom.
Thanks, Sonia. And I think that's, it's really always important for us to hear from people who are actually practicing virtual care in the mental health space and understand how that works. And it was interesting to see some of the statistics that you showed us. And we'll definitely want to come back to that during the Q&A session. I'd like to pass to Herbrand now, and he's going to give us a perspective from a Chief Digital Officer, which will give us another interesting dimension on how to address this. Over to you, Herbrand.
Thank you, Tom. Hope you can all hear me well. From the mental behavior perspective, to give you some background, mental behavior is treating 50,000 mental health patients a year with our 1,300 therapists. And if you can put on the slide, please. The way we do that is based on three main pillars that I want to outline here. first pillar is the platform, and Shihan already mentioned that, but the platform is the basis on how we treat our patients in a digital way. So there are three main ways of treating patients. That's either face-to-face, blended, or fully online. Those are the three flavors that we have when it comes to treating patients. And the platform is the basis for all that. As the previous speaker, we also use the Engage platform to do that. And the Engage platform really enables us to incorporate the patient journey into a digital journey. So what we've done, we've mapped our care pathways together with our care plans into our platform, and we use that to really facilitate the client journey, which starts from ideally already in the prevention cycle. So that's an area where we work on right now, where we try to get consumers even before they get patients into our ecosystem, and we can serve them, for example, with prevention modules around sleep, resilience, and so on. Once they become a client after intake and diagnosis, we serve them a care plan consisting of questionnaires to do outcome measurements and to guide them into the right care pathway within our platform. And this really helps, on the one side, the patients to be really engaged. On the other hand, the clients, the providers, to get all the right information at the right moment. And this platform, of course, is integrated with our EMR to make sure that our providers have all the right information at the right moment when they're sitting in front of the patient, to prevent that they have to switch from one system to another. The second really important pillar is data. What we've seen within Mental Beta is that we have tons of data about patients, about different treatment paths, but it hasn't been used in the most optimal way. So we're currently working to further optimize the use of data and algorithms, for example, to do patient and provider matching. Because we have tons of outcomes data from the last 12 years, because that's how long we have been measuring outcomes. We're not trying to turn that into algorithms which we can use to match a patient against a provider, to see if we can make sure that we match the right patient to the right provider, to ensure that we get the best outcomes possible for the patient. And another really interesting element of that is that we're now looking at how can we use the data from third-party devices like activity trackers, but also sleep. You might all well know that there is a clear relationship between sleep and depression. So we're now looking at using sleep data from sleep trackers within the platform to predict specific outcomes and to ultimately assign specific content and care pathways to the patient. The third and last pillar is content, which is really important for us. I think a couple of years ago, Bill Gates mentioned content is king. I fully agree with that. So we're really investing a lot of time and money in developing state-of-the-art content and including that into the Engage platform to make it available for our patients to use. And this content is like the traditional e-mental health content, but instead of serving real big chunks of e-health lessons to patients, we really try to focus on micro content, where we serve them single bits and pieces of e-mental health content that really help them as part of their personalized care journey. Another example of that is VR. We have been investing in VR for the last couple of months, for example, for trauma therapy, which really, and another example, which really helps and patients really appreciate that. And the other example is EMDR, digital EMDR technology that we have been integrating into our platform. And the good thing about this combining platform content and data is that at every point in time, we can serve the right content to the right patient almost fully automatically. And in addition to that, we can measure the outcomes of the intervention that we've served to the patient and give feedback to both the patient and the provider to see what the next logical and effective step is in the treatment of the therapy. So that way we're combining all these three elements in a way that we can deliver better care in an online way, which we had to do during COVID. I think Shehan already mentioned online treatment is more than only video calling, and the previous speaker also outlined that, because that's still what people think is online therapy. But we really want to take and are taking that next step in which we turn treatment into a really intelligent way of serving care, most of the time without face-to-face or through video interaction between the patient and the provider. That's only one step in the whole treatment path. It's not a must-have. There are multiple ways of treating a patient through an online platform. So those are the three main pillars of our approach when it comes to digital therapy.
Thanks, Brand. I found it as a digital person, really interesting and some great insights. And while we're talking about digital in the context and virtual care in the context of mental health, in fact, Brand's hit on three of the critical areas that are important with digital adoption. One being that the digital experience has to be intuitive and it has to guide you to the right outcome. The second one being that most of the successful uptake in digital is where people can access content that's relevant to them and helpful at the right place at the right time. And the third one, which I think is a really interesting challenge we might pick up in the Q&A, Brand, which is the one about data, because systems tend to generate huge amounts of data, but how do you actually use that data for real, genuine insights and action? It's probably the age-old challenge that the whole IT industry has dealt with for years now. So let's change speed one last time. I'd like to hand over to Andrew Dempster. Andrew heads the advisory services for KPMG focused on mental health, and can kind of probably give us some interesting industry insights, probably particularly for the Victorian context, but maybe in other contexts as well, as Andrew does play nationally in this area. Thanks, Andrew.
Thanks very much, Tom, and it's really great to be with you this afternoon. As Tom's highlighted, I lead our national mental health advisory business, and as part of that, I get to work across the country with service providers, with consumers and carers and their family members, and government health departments. And in a lot of the work that we do, really a focus has shifted in terms of looking at virtual care, looking at digital health, understanding the way that face-to-face and online or virtual care is provided. And I just wanted to really this afternoon build on some of the earlier speakers and the points that have been made about direct care to focus on what we're seeing at a national level. And really what we're seeing, and I'll put my first slide up if I could, to highlight a few of the, I suppose, key reflections that we are seeing. And I'll just move it on from that cover slide, thank you, to punctuate the points that really we're seeing a proliferation of virtual care models. We're certainly seeing a lot of telehealth, a rapid expansion of that, and a good example is the MBS, so Medicare Benefits Schedule, mental health consultations. We're seeing where they were, 2% or lower a couple of years ago, we're now seeing almost half of those being provided through telehealth in the pandemic. We're also seeing people reach out in record numbers to some of the helplines and also virtual support lines, so Lifeline, Beyond Blue, Kids Helpline and others. Again, it's not part of that virtual care platform, but really ad hoc and people using digital mental health supports and services more and more. We've also got an expansion of some of the online apps that we're seeing, CBT-based, mindfulness-based, people who are accessing chat support services, but really using them in an ad hoc way, and that's an unregulated system. And then interestingly, what we're seeing in mental health service provider side of things is hospitals, community mental health services, individual practitioners providing virtual care, but largely telehealth and video health options, and often doing that through ad hoc systems, so through Zoom or FaceTime or other sort of add-on supports, and really augmenting what they are doing in otherwise a sort of an in-person or face-to-face care. So there's a real opportunity to actually build in some degree of choice, flexibility from both the consumer of service end, but also the clinician end. And I think we've heard really great examples where Herbrand's highlighted what the directions they're going in the Netherlands, and the comprehensive suite of services they're able to provide in those sort of three options of sort of both face-to-face, mixed and virtual. And Zonia giving that practical example of how they're supporting people with borderline personality disorder to actually seek out to really integrate the services they're providing, and also kind of build in greater interaction between clinicians and the consumers, so that they're avoiding some of those otherwise crisis calls, or also presentations to emergency or unplanned sort of admissions to hospital. I think we're also seeing a need for common platforms. One of the biggest challenges we see that people in adopting virtual care is that they don't have those shared systems and platforms, and people are ending up having to retell their stories time and time again. One of the real frustrations we hear from consumers is, I'm having to retell my story. I've gone through an assessment process already. Do I have to do this again in a hospital setting, in a community setting, in a private practitioner setting? So the real opportunity there is building in those models that actually can avoid the retelling of that story. And I think importantly, what we're seeing is the research is emerging that there's actually really real promise in the outcomes being achieved through virtual care, that they're as good, if not better in some instances, than face-to-face care. I think we're seeing a mix of promise with different apps and supports like Philips virtual platforms, where sensors, self-assessments, data about sleep, social activity, mood are actually provided in a really clear, consistent way. They're connected to clinicians and actually allowing for greater integration of support and also proactivity from the clinician end, so they're not just waiting for an appointment. And ultimately, that avoids some of the traditional barriers that we're seeing too. I think when you open up virtual care, we think about the reduction in travel time, the reduction in costs associated with seeing people face to face, the potential for greater access to services for people living in remote communities, linguistically diverse communities, so better matching of clinicians and service providers to people that might be having someone from the same background, language, being able to link those individuals better. And I think a really good recent example has been a model where the University of Queensland have actually set up virtual care models based on CBT and traditional healing practices to allow the continuity of services and supports to remote Aboriginal and Torres Strait Islander communities up in the Cape region, so that they're not disrupted by some of the restrictions that they've had. And I think the other area that we kind of need to focus on is 5 years ago, we really didn't have the funding available for service providers to provide virtual care. We now do, although those funding models are still, if you like, evolving. So I think we've seen a real boost in the telehealth models and the services that are out there. There's been a recent, over $100 million announcement by the Australian government to support increased telehealth over the next 4 years. And that's really been expanding. State-based services, we've also seen, particularly for outpatient models, a number of ways of adapting that to virtual care and the supporting funding that goes with that. But it's still adapting, and it's not quite aligned yet to that true multidisciplinary model of care that we provide in mental health, particularly in the community settings in an ongoing basis. And all of these things, I should say, are particularly important, as Shahan highlighted earlier on, for people who have complex conditions. They may be dealing with not only mental health issues, but also chronic medical conditions, is connecting up the care between the clinicians in the community, the physical acute services in hospital, but also the interfaces with community mental health. So really being able to join those services up and the supports, and virtual care platforms actually provide a way of doing that in a joined up, comprehensive way. On that note, I'm mindful I'm probably about at time. Tom, I'll hand back to you and keen to get into the questions.
Thanks, Andrew. Yeah, look, very comprehensive. Really appreciate that range of insights that you bring to the topic, and you can see Andrew's got a lot of expertise and personal insights to share. I would like to, as Andrew says, just mindful of time, get straight into the Q&A, and I'm keen to use the questions coming through Pigeonhole. And we've got plenty, but just a reminder that you can both post questions there, but you can also vote on questions, just so we prioritise the ones that are most important to you. So feel free to vote even if you don't have questions you'd like to add. I am going to pose the questions to individual members of the panel just for ease of response, and we'll be looking to keep the responses relatively net, just conscious of time. But at the same time, if any of my panel feel that this is a question they want to contribute to, then please don't hesitate. So Shahan, I might ask you, as someone who has a regional role, how does mental health treatment in Australia compare? And I guess looking at this through the lens of virtual care, but from what you see around other countries and around the region, how does Australia compare to other countries in this space in terms of mental health adoption of virtual care in the mental health space?
I think Australia is, like a lot of health systems, is on that journey. I think a lot of virtual care focus has been traditionally on chronic disease management. That's where a lot of people have cut their teeth in virtual care. So from a global perspective, I don't think we're necessarily lagging, although you hear from individuals such as Herbrand that are in the Netherlands, they have a much bigger adoption of digital in the mental health space. I do feel that in Australia, we do have a legacy of thinking about virtual care as telehealth. And so there is an opportunity for us to think a lot broader than that, which is what we're exactly talking about today, right? So it's about not just a video consult, but it's also about monitoring that patient in that home environment, covering not just screening questionnaires, outcomes measurement, but also metabolic monitoring to support the physical well-being of that individual.
Thanks, Shahan. And I've got a question straight away there for Herbrand that kind of builds on that. There's a question here in the chat around, are there issues around digital literacy in properly accessing virtual care? So you talked a lot about the features that are built into the platform, but do you see challenges, Herbrand, in take up of the platform where people just don't have the digital literacy to understand how to access and use them?
No, thanks for this question, because this one is spot on. And so we always have to keep a close eye on and really know our patients. Are they able or willing, of course, to use digital tools in as part of the treatment cycle? And this is really up in the intake phase of our treatment path. We really try to address this to see if is this patient capable and, of course, willing to use digital tools. We're also looking for screening instruments around that. There are some in the more somatic space for self-measurements for diabetes and COPD patients. There are tools that can be used to measure if a patient is capable of doing some level of self-measurement. There are not a ton of those in mental health, so we're looking at that at this moment. But that's also the reason why we have at a high level 3 channels. It's either fully face-to-face, no digital tools at all, because the patient is not willing, not digital savvy enough, or whatever. Blended, where you combine face-to-face with digital, or fully digital. And those are the 3 flavors that we offer our clients, depending on the profile and also on the request of the patients themselves. The patients are in control in this matter.
Cool. Thanks, Brand. That's a helpful insight. Sonia, I'm going to we've got plenty of questions, so I'm just going to keep throwing them to the panel. Sonia, I've got one for you. You're, just for context for people, you're in the middle of what is really a fully featured virtual care capability. But looking at that mental health space as someone who operates a virtual care capability, are there dimensions of care for mental health that are not well suited to virtual care, or is there a blend of virtual and face-to-face that's really necessary to give people the best care, do you think?
I think the blend is maybe the best idea, like Herbrand was just saying about those three different ways. And I think we've seen that definitely, that some consumers initially are maybe not so keen to go on virtual health, and it takes a few tries to show them and to educate them about how it works. Eventually, we've seen that the ones who was really hesitant in the beginning becomes our biggest advocates for virtual care, which is quite interesting. But yeah, there's definitely cohorts that we are more apprehensive about. So, for example, the paranoid schizophrenic population, we are going to take it very gentle and very step-by-step if we incorporate them into virtual care.
Yeah, that makes a lot of sense, and I can see why that cohort would be particularly one we'd have to take baby steps with. Andrew, and happy for you to add to that one, but just throwing one specifically at you, there's 2 or 3 questions here that really go to the question of things like funding and costs, and to kind of try and put all 3 questions together in one for you. The questions are around, if people adopt virtual care, does that drive cost efficiencies? And, does the government funding provide a genuine incentive, putting aside the telehealth bubble we've seen for GPs? Does the government funding, is it adequate to drive the uptake of virtual care in this space? And then just to round the question out, we're going back to that GP example, is the funding driving the right behaviours? So is it driving uptake for the sake of uptake, or is it actually changing the way the care is delivered?
Yeah, look, it's thanks for that question, Tom. Yeah, is government funding adequate? It's a good one to answer. Look, I think what we're seeing with regards to funding is that the service models and the technology are advancing faster than the funding models. So the funding models are playing catch up. I think while they're advancing, there is still key challenges to consider, as I sort of highlighted before, when we're looking at the existing service models in a face-to-face way, where we might have a community mental health service providing, it might be a psychiatrist, a nurse and a psychologist providing different care with a dietitian input over a period of time. The complexity of some of that sort of funding arrangement and how that's billed is still certainly not there in a pure switch to virtual environment. However, very much the one-to-ones are, and I think that the telehealth component is there. Some of the connections that are had, it's actually there in funding, but it's actually the way that services are now trying to code and adapt those mechanisms that they're using that are perhaps traditionally weren't clearly funded, where it's not just a pick up the phone, it might actually be an online connection or a checking in of particular tools that clients and consumers are using, where it's actually looking at, well, we've already got this coding here. It's how we adapt and adopt that to best meet those sort of funding requirements. So I think it's still got a way to go, but there are services out there that are adapting and being able to kind of get ahead so that they are supported in these newer models.
Thanks, Andrew. Herbrand, I'm going to throw this next one at you, even though it's actually quite an Australian-specific context, because I'd love to get the international perspective. You may or may not know that in Australia, we've had real challenges in adoption of digital health and virtual care with concerns around privacy and confidentiality. And we've struggled to balance building the capabilities into the technology to support that and not doing it to an extent that actually limits uptake and actually drives people away from adoption. Interested in the kind of the international experience in that space. Do you see similar challenges, and is there anything in the way that you've rolled out your technologies that are designed to address those concerns?
Yeah, it's a really good question. And if you look at the European perspective, it differs country by country. So if you look at the German and Austrian and Swiss privacy laws, for example, they're far more stricter than the ones in the Netherlands. But all in all, from our perspective, for everything we do, we need the patient's consent, and we try to communicate as clearly as possible. What are we using the data for that we collect? Why are we doing this? It's not to collect some kind of gigantic database with all kind of data. It's just to help you get better treatment. And we really encourage our therapists to start this conversation with their patients, to explain them why are we using digital tools, because we really believe and we can show that it really helps improving the care for the patients. But the conversation between the patient and a therapist, and the trust level that exists between a patient and a therapist, is key there. Otherwise, you become the next Google or the next Amazon, trying to get as much data in as possible, and you really have to prevent that.
Yeah, look, and I think that's a fantastic point, Brandon. I think, I've been involved since the early days of the My Health Record in the digital health space in particular. And I think it's part of the challenge in overcoming it is to give patients in particular confidence that the data is only being collected in order to deliver better care, and that no one's ambition is to collect, as you say, a big pile of data for the sake of hoarding the data, but there's actually only an intent to provide better care to patients. And I think when patients are aware that the data is only used for their care, then a lot of those confidentiality issues drop away. But it's certainly still a challenge for us. I'm going to throw the next one to Shihan, and then Zon, you might want to comment afterwards, because it's kind of a mixed technology industry question. And the question is, how can virtual care play a role in filling the missing middle, often referred to in mental health care in Australia? And that missing middle is the gap between initial diagnosis and treatment and high levels of care. Or another way of looking at it would be, that people move between care settings, and therefore you lose track of exactly where they are in the process. And it probably comes back a little bit to your comment about care plan, Sharon. So I'd like to hear from you on that, and from a virtual care platform perspective, and then maybe from Zonia in terms of how that's being applied in the West Moreton context.
It's a great question, and I think it's a role that the virtual care platforms can play a really big part in, because fundamentally the role of the virtual care platform is to wrap around the consumer and the patient to be able to capture their information in one place. And this whole concept of a shared care plan. So, we talked about the fact that good care means that the patient is part of that care plan, but also we know that proper mental health treatment includes multiple facets, or it's not just about your mental health condition, as we discussed, it's about your physical conditions as well. And that means that multiple clinicians are going to get involved in the care of that patient. So as Andrew mentioned before, right, a big issue for a lot of patients is I'm having to repeat my condition over and over again. Now, because it's all captured in the one platform, and because it's independent of the location that patient is in, that information is all contained in the one place, so that when a clinician wants to provide treatment to that patient, all that information is already there and presented to them, which is a key part of how these platforms are being developed, in a way that information can easily be absorbed and used for better treatment.
Excellent. Thanks for that. That's a great answer. And Zonia, before I throw to you, I'm just going to give you a bit more context. There's another question that kind of brings more more context to this particular question. Can virtual care be used to give people more certainty and continuity about their diagnosis? Many people are burdened with changing diagnoses, and therefore, by getting a consistent view of the diagnosis, actually get the care that they need. So I just thought that might actually brings that into stark relief, that question that we were just addressing through Shihan's answer.
I think the beautiful thing about virtual care is we actually walk the consumer journey with them. So traditionally, a consumer will come in for 1 hour of therapy, and we'll have to make a diagnosis within that 1 hour. If you're lucky, you get maybe 3-4 hours. Now we can actually ask them to self-monitor over a longer period of time. We get more diagnostic information, so our diagnoses are, I think, more on par. I think the other thing that we can see is with the virtual care platforms is that we are linking with GPs, we are linking with nursing, we're linking with the whole multidisciplinary team within this one platform. And again, it allows for the consumer to be seen by the multidisciplinary team, but not tell their story over and over and over again. So I think in terms of care throughout, from the hospital to the private health network, from our acute care team to our emergency departments, it's all actually done in the one platform, which is really positive for the consumer.
Yeah, for sure. I think that's a great answer, Sonia. And I think that means that we have to see sort of unified adoption. So you're in a position where you've done a great job of actually identifying a cohort and managing that journey end to end with them. It feels like Herbrandt's world is a bit the same, and that's certainly the ambition that Shihan talks about for the Philips platform, which, you know, we're a big fan of. But at the end of the day, I think a lot of people don't get that consistent engagement. They get different engagement from different providers, different platforms, and that creates part of the problem. Andrew, there's a question here that kind of touches on that I might throw to you, is what role can government play without spooking the horses around privacy and confidentiality to try and ensure that the data that's available is shared between those different providers and platforms so that people do get that continuity of journey?
Yeah, I think in a way, and this goes to the whole spectrum of digital kind of mental health care, and, you know, from apps and crisis lines through to, you know, comprehensive platforms like the sort of virtual care models we're talking about. There's a question of, well, there's lots out there. Which ones do I go to? What's reliable? What's a better practice model service here? And I think with regards to government, there's a point about the telehealth funding at a Commonwealth level and the state outpatient funding and the block sort of funding, for want of a better term, in a hospital setting. That this is an area where government should be co-commissioning that missing middle, if you like, so that there are people who need more than just that one-to-one care with perhaps a GP or a private psychologist or psychiatrist, and might have a mild sort of condition, and the difference between that and the very comprehensive sort of multidisciplinary team models that you see in inpatient care in mental health. This is an area where it is really primed to say, okay, well, there's opportunity to actually co-commission services here and actually use some agreed, you know, virtual care platforms to provide these services, where it might be more than just, as we've heard, a GP. But it's not kind of the whole environment that you would have in an inpatient type setting with a, you know, a team of people. It's connecting people better. So I think there's an opportunity to actually, really trial some co-commissioning and funding. Awesome.
Thanks, Andrew. Look, we've probably got time for two more quick questions, and then I'm going to wrap and hand back to Cassandra. So this one I'm going to throw to Sonia and then Shihan, and then I have one very specifically for Herbrandt to close out. So historically, and I know it's different for different states and it's improved over time, but historically, mental health presentations in emergency departments has been a bit hit and miss, depending on whether that emergency department is actually equipped to deal with mental health presentations. Is there a role, Sonia, for virtual care, or is there already a role being played in your environment for virtual care actually supplementing the capability of an emergency department to deal with a mental health presentation?
About supplementing. So at the minute, we are trying to avoid ED as much as possible. That's our first point of call. The second thing that we're trying to educate our ED department is that people actually access us over the platform whilst they're in the ED department. That means that
yes,
we can respond quite quickly when they're in ED, reduce those waiting times in ED, and get people out of ED as quickly as possible and provide the right care for them. So that's what we're currently working on. With our acute care clinicians, we are now at the point where we're getting them onto the Engage platform as well, because they can see what skills we've taught consumers already, and they can advocate for those skills or facilitate those skills to be utilised by the consumers in the emergency department, which makes care better in the end of the day.
Excellent. Thanks, Sonia. I think that's a great answer, and probably does help bring that into stark relief that it's maybe more about getting people the right pathway as they arrive in ED to get that virtual care and get them into the right pathway. Shahan, I just want to give you a chance to add if there's anything else from your perspective you want to add on that topic of ED care.
Very, very small addition to it. I think the opportunity that virtual care presents is also around faster triage, because you can get access to clinicians that are in short supply, and those clinicians could be in a more central position. And of course, then if you're able to triage them really quickly, you might be able to enroll them onto an existing mental health program that provider network has, and discharge them quickly into the home because they're already supported, right? They're not unsupported, because that's always the challenge in all of these spaces, is when somebody's in ED, how do you support them through that next care pathway? And that next care pathway could be to go back home and have a support network around you, which is the opportunity virtual care can bring.
Awesome. Thanks, Shahan. Strongly agree with that. And Herbrand, just we'll keep the answer pretty short, but there was one specifically here for you, which was, you talked about content, which we haven't really covered a lot since your actual speaking role. The question was around, how do you balance giving people access to content versus overwhelming them with content when really what they're looking for is someone to engage them and help them?
Yeah, it's a good question. The content is a broad definition of what content is, and in our definition, it's a combination of micro content, so not throwing like full-blown big chunks of content at them, but break it up into micro content. And it could be like one lesson on like what's depression or how to handle anxiety. It could be just one short movie that explains the concept and then helps them in their treatment journey. So I fully agree with you have to be careful with like throwing tons of content at people. It also depends on the profile of the patient, what content is applicable for that patient in that patient journey. But I'm a big believer in micro content, where you combine the best of multiple worlds into one platform and serve it to the patient at the right time.
Excellent. All right. Well, look, I'd like to thank Shahan, Sonia, Andrew, and Herbrand. I think it's been a great panel, a great conversation. There are a couple of questions left. As opposed to answering those, what we'll be looking to do through CEDA is release a couple of insight papers that will sort of take on board the feedback and the questions from today and try and provide you the best insights we can as a team on this topic. But I've certainly enjoyed hosting, and I hope you've enjoyed listening and participating through the Pigeonhole question and answers. I'm going to hand back to Cassandra. Thanks again.
Thanks, Thomas. So unfortunately, we are out of time. I hope you really all enjoyed that fantastic discussion. I know I did. So thank you so much to our panel, Shahan, Sonia, Herbrand, and Andrew for sharing their insights and expertise. And of course, to you, Thomas, for your excellent facilitation. I'd like to thank our live stream sponsor, again, Philips, for your ongoing support. Really allows CEDA to continue these really important discussions on key policy issues. And of course, thank you to our audience, all of you for joining in today and participating on Pigeonhole. It was great to see so many questions come through. Look out for the post-event email, which will include a link to today's recording. And I would also ask that you take a moment while you're still on Pigeonhole to rate your experience. You can find details of all CEDA's upcoming events on our website, which is ceda.com.au, and that's including our flagship Economic and Political Outlook event series, which is starting in Sydney on February 16. So I encourage you all to go take a look at the website and sign up for something that interests you. There's plenty there. Thank you, everyone. It was great to have you with us today.